Well, thank you all very much for joining us this morning. My name is Ruth Cologne Wagner, and I welcome you to the New York State Care Management Training Initiative. I'm with NYAPRS, the New York Association of Psychiatric Rehabilitation Services. Today you are joining us for webinar number 4 in our 5-webinar series. So we really are in the home stretch, guys. Today's topic is workload management, strategies, and using technology to enhance productivity and our effectiveness. I also want to just give you guys some information. At NYAPRS, we have Judy Stevens, and she's providing us with very excellent outreach and support for this program. And so please know that if you have a question, if we have a question, we may be in contact with you, and it may come directly from Judy's email instead of my own. Again, her name is Judy Stevens. And I also want to take this opportunity to remind you of the next couple of activities in this series. And so after today, for the supervisors, we have the All-Region Supervisor Learning Collaborative Call, and that's going to be on October 6th. And then also for the supervisors, we have then the regional calls broken down by regions. And for the Western and Rochester, that will take place on November 3rd. For Central, Utica, and Watertown on November 4th, and Northeastern and Northern Metro on November 6th. And we are actually skipping December for obvious reasons, as so many people are busy during that time of year. And so the 5th and last webinar in this series for both supervisors and care managers is January 5th, 2016. And then after that, we will follow that up with our typical supervisory track activities, which include the all-region call and then the regional calls, and then we'll wrap everything up with our supervisor face-to-face. So before I introduce you to the presenters today, there are a couple of people in the audience, Paul Margulies and Nancy Covell of the Center for Practice Innovations, and Diane Neufel of the New York Care Coordination Program, who is very busy working in the background. So now for today's presenters, we have Adele Gorgeous. She's the Executive Director of the New York Care Coordination Program, and as Director, she's responsible for overseeing an extremely complex set of programs, clinical, regulatory, fiscal, and technical initiatives designed to improve services for people diagnosed with serious mental illness. In addition to her strong project management capabilities, she brings to the project significant experience in the behavioral health finance field. She has presented on the New York Care Coordination Program in a number of forums, including the American Psychiatric Association and the New York State Association for Psychiatric Rehabilitation Services, or NYAPRS. Prior to joining PCSI, Adele served as Director of Finance for Rochester General Behavioral Health System. She holds a degree in political science from Manhattanville College. Our next presenter today is John Lee. He is the Director for the Center for Collaboration in Community Health. John is the Director of the CCSI Center for Collaboration in Community Health, and he has worked for both Community Care Behavioral Health Organization as well as Beacon Health Strategies. Most recently, his role is Program Director for the Western Region Behavioral Health Organization Initiative. Additionally, he served as Vice President for Highland Hospital of Rochester for a number of years. John holds an MBA with a certificate in Health Administration from Cornell and is currently a member of the New York State Behavioral Health Advisory Council. Also, I'm pleased to announce joining us today is Christine Mangione. She's a registered nurse and a certified case manager with both managed care and direct care experience with adults and children in emergency inpatient and outpatient settings for treatment of behavioral health and substance abuse disorders. She is currently the clinical director for Health Homes of Upstate New York. Recent work with Beacon Health Strategies in partnership with NYCCP includes the development and implementation of a complex care management program to better serve the needs of complexly ill individuals and manager of clinical operations for the Western region. A partnership with NYCCP, Beacon, and CCSI. She has spoken on several statewide conferences on the subject of health home care management, including the Acclaim Conference and the New York State Care Management Association, as well as the many regional meetings organized by the Western Regional Behavioral Health Organization. She's a graduate of Johns Hopkins School of Nursing and the University of Rochester. So with that, we've got these wonderful presenters here today, and I thank you all for joining us.
Thank you very much, Ruth. Thank you for the opportunity to be a part of this webinar today. A couple of real quick housekeeping details before we get into the actual presentation. Please feel free to use the chat box if you have any questions during the presentation, and we'll work on answering those at the end. Also anticipate that there will be a post-event survey available, and we really would appreciate your feedback to make sure that we understand what worked well and where the opportunities for improvement are so that we can continually improve the educational opportunities that we offer. Also, because it is often asked, will this PowerPoint presentation be available after the webinar? And certainly it will be. And if you hear a little bit of noise, we've got a train going by. Hopefully it won't interfere. So again, the topic of today's webinar tied to health home care management services is in the area of effective outcomes measurement and management. And really, what we want to talk about today is how to address quality assurance and outcome expectations tied to the delivery of health home care management services. And as you can anticipate, this is a very, very important topic as we all continue to prepare ourselves for the transforming Medicaid managed care delivery system, and as we seek to assure that we are able to demonstrate accountability for the key outcomes that drove the development of health home care management in New York State. So more of that as we continue, but just to remember how important this conversation is to our future success and our ability to really impact the individuals that we serve. So the learning objectives today include understanding expected outcomes resulting from the work of New York State health homes, understanding how health home metrics can be tracked and reported, understanding the key elements of successful health home quality assurance programs, understanding the types of reports needed to monitor performance and the types of reports that are already available. We'll show you some of those. And we're going to take a little time to review an audit tool that is being used to really review the quality of the reporting that's done and provides an opportunity for downstream care management agencies to really make sure that what they're documenting is what will be necessary to demonstrate impact. So to start off, we just want to go through a couple of fundamentals, and these are phrases that we use periodically. We always think it's helpful to take a couple of minutes just to make sure everybody understands what these phrases really mean. Quality assurance. Really, a quality assurance process is a process that's used to make sure that we're basically following the key processes that we said we would. Sometimes you hear language, fidelity to the model. What that really is saying is we say we're supposed to deliver services in a particular way. We want to make sure through our quality assurance process that that's exactly what we're doing, and if we find we're not doing that, we have an approach to take to make sure that we move towards fidelity to the model. Quality improvement is really that opportunity not to just say that we're doing what we said we were doing, but that what we're doing is having an impact on the individual that we're serving, that the outcome of that individual's engagement, in this case with the care management agency, results in an improvement in their quality of life and their use of services, things that really are clearly a part of the established outcomes for health home care management. And the last point, outcomes management, really is the use of continuous quality improvement practices within healthcare to assess the effectiveness of the products and the services and the quality of the support that we're providing. Again, really demonstrating outcomes will be critical to the long-term success, not just of health home care management, but so many of the services that we provide in support of Medicaid recipients. So why focus on quality and outcomes? I think I've already mentioned this a little bit, but just a reminder that the Affordable Care Act does provide an opportunity to build person-centered care delivery model that does focus on improving outcomes and disease management. That's the source of the health home dollars. And again, with that investment comes an expected return. Certainly, we all understand as health home leads as well as health home care management agencies that there are required reporting expectations. Some of those continue to evolve as we develop our relationships with managed care companies, but we have this accountability. We need to make sure that we're doing our work in a way that demonstrates impact, and we're doing that as efficiently as possible. Also, there are recommended health home core quality measures that really play an integral role in the larger payment and healthcare delivery system. We need to be mindful of what those quality measures are and do work that really has a positive impact on those quality measures. So when we think about quality and outcomes, it's so important that we recognize that in doing this work, we are really doing it so that we can demonstrate that we're having an impact on the individuals that we serve. So what I'd like to do now is turn the session over to Christine Mangione, who will spend a little bit of time talking about the desired outcomes for health homes.
Thank you, John. I'm passing this laptop back and forth. So John mentioned what about outcomes and quality measures, and we're going to start with looking at the core set of quality measures that have been established for us by the Centers for Medicaid and Medicare Services. The first is adult body mass index assessment. I think what goes along with obesity, oftentimes there are many chronic illnesses such as heart disease and diabetes. So it makes sense that we be paying attention to the adult body mass index. Ambulatory care, so we want to see that people are connected to service in an outpatient level, hopefully in an effort to avoid inpatient stays. Care transition, so that we want to be sure that if an individual is at one level of care, that when they transfer to another level of care, that health record goes with them to the provider who will be supporting that individual. Follow-up after hospitalization for mental illness. Here we're looking at appointments within a specific time frame to be sure that that individual, again, transition is as seamless and supportive as possible. Looking at all-cause readmissions. Avoidable readmissions is one of the focuses of outcomes for this initiative, and we're looking at all reasons for readmission. Screening for clinical depression and follow-up, so not just the screening, but and this is screening for clinical depression for all individuals, not just those who are seeking mental health or substance use services, but also those seeking physical health. Oftentimes depression goes along with that. If they screen positive, they're going to be looking for a follow-up plan, treatment, connection to service. Initiation engagement of alcohol and drug dependence treatment. I think that's pretty self-explanatory. And also controlling high blood pressure. The next set of quality measures comes from the New York State Plan, and what I want to mention is that all of the quality measures are really interrelated. So these primarily address reducing utilization associated with preventable inpatient stays and emergency room stays. We're looking for improved outcomes for persons with mental illness and or substance use. Going back to the previous slide from the Centers for Medicaid and Medicare, they're also looking to see that there is a connection for individuals who have been diagnosed with substance use and mental illness. Looking for improved disease-related care for chronic conditions, and very importantly, preventive care. So providing services prior to the full-on development of an illness, of a chronic disease. So what's the state expecting from the health homes who are delivering services? Well, they're looking to see that the population being served in a health home is experiencing improved health care, and it will show up in the health care outcomes. They're looking to spend less money on health care over time for Medicaid recipients. We're looking to reduce preventable hospitalizations and ER visits, again, going back to the state plan and to Centers for Medicaid and Medicare. They're tied together. Avoiding unnecessary care for Medicaid members. What does that mean? So that the right service at the right time. People are not going to the emergency room to address a cold. They're going to their primary care physician. Avoiding escalation of services and costs from unmet needs. Again, that refers back to preventive services. And let me just see here. The next is developing a quality program for health home care management. And here we go. Huh?
We're passing the laptop one more time. Thank you very much, Chris. So what we wanted to do is spend a little bit of time talking about how you begin to develop a quality program to support health home care management services. And the first thing I would say is don't feel as though you have to start from scratch. If you already have a quality assurance, quality improvement, performance management program in place to support other services, think about how the work that you need to do to assure quality in health home care management delivery can be folded into that. Not only will it allow you to be a little bit more efficient, but it will also give you the opportunity to see what kind of synergy may result from effective care management services in conjunction with the delivery of other services to that same population. So think about it as just a really good opportunity. So if we think about the development of a quality program, we start with the program structure. And again, first question is, how will these quality assurance activities be integrated into your agency's existing quality activities? So think that through. Next is to make sure that there's a point person identified for health home quality assurance activities. Who really is going to be the person responsible for managing this process, collecting the information, understanding it, or making sure that it's reviewed and understood, and then taking the responsibility to track to make sure that there is some follow-up as a result of that. This person doesn't have to know everything about health home care management, but they need to be willing to track from a project management perspective all the steps that you've identified as being appropriate. Resources. Assess your agency's ability to collect and analyze data. Again, you may be getting reports that come from your health home lead. You will be getting reports that come from the state. You need to make sure there's somebody available that can look at those reports and let others within the agency know what they really mean to the work that you're doing. Identify other oversight entities that provide you with information and feedback, and make sure that you understand what those expectations are. Remember, it's always important to know who your customers are. That's often driven by who's paying the bill and what their expectations are. So think about this even in terms of the managed care organizations. We see more and more that managed care organizations are beginning to set expectations for the health home care management agencies that they work with. It's so important to understand those, to build a relationship with the managed care company or with the health home that has the relationship with the managed care company, so that you can really understand and continue to meet their expectations. And in meeting their expectations, we're certainly expecting that you will be delivering good services to Medicaid recipients. In terms of communication, define how your agency, QA administrator, will ensure the information about performance is shared both up and down within the organization. When we have information about performance, it's so important that we share with senior leadership, with the board of directors, so they understand here are the challenges that we're facing, especially if you're going to require some sort of investment. It's so important that they understand that. And clearly, how can you really expect your care managers to do things differently if you're not sharing the feedback from the reports that you're getting to let them know, hey, there are opportunities for improvement, and even to allow them to think with you about what changes may be necessary or opportunities may exist to do better work. Then in terms of your process, you need to make sure you've thought through each step of the way, what will happen in order to support continuous improvement, to always make sure that we're looking to do a better job in supporting those individuals receiving care management services. So some of the steps, and this may, again, be unique to each agency, but think about these steps. Training staff on the requirements and developing policies and procedures so that everybody's clear on what is expected. Documentation is important, and not just documenting, but sharing that document and making sure people understand the content. Making sure that you've created some methods for collecting information to assess quality of services, and we're going to give you at least one example of that as Chris shares an audit tool. Make sure that you have a quality review committee, a group of individuals, it can be clinical and administrative folks, that will review the audit findings, the interpretation of others, that make their own interpretation, to make sure that we have a good understanding of where we stand and where we need to go in order to improve our outcomes. When you do find that there's a clear deficit in meeting expectations, it can be very important to develop a plan of correction to address those deficiencies. You may be used to thinking about a plan of correction that comes to you from another oversight agency, but don't think that that's the only place that a plan of correction should emanate. Really, if, as an organization, if you want to continuously improve, you may say to those folks within your organization, let's figure out how to do this differently. Let's not wait till somebody comes down and says, okay, tell us what you're going to do. Let's figure that out ourselves. And certainly once you got the plan of correction in place, monitor it. Are you doing the work according to the plan of correction? Are you seeing the impact? And as we said before, regular meetings to keep the staff informed is so important. You can't expect them to change without really understanding where the opportunities are. Some other steps in developing a quality program. Participate in quality improvement activities offered by the health home. Some have learning communities, some have webinars, some have work groups. Really make sure that you're aware of those opportunities and you're participating. That is how we learn. I know some of us think, oh, we've been at this now for a couple of years. The reality is we've only been at this now for a couple of years, moving into the third year. And there's a lot for us yet to learn, and one of the best ways of learning is to share what's worked among agencies and the learning that we developed from really talking with one another. Again, also participate in all the trainings offered by both the health homes and the state, and what we've included in the PowerPoint that you will receive after the webinar is concluded is some links to sites where you can go to get up-to-date information about trainings that are being offered. What I'd like to do next is turn it over to Adele Gorgeous, who will share a perspective in terms of assessing performance.
Thank you, John, and good morning. Let's talk about assessing performance. And I think the place to start is the fact that it's everyone's role to actually monitor performance to ensure quality and make sure that the outcomes are met. What we'll do is take a look at some examples at each of the different levels within the health home structure on how you might approach assessing your performance. The first of those levels is at that of the care management agency. Then there is the health home level, We'll look at a data analysis tool at that level. Managed care organizations are very involved in assessing the quality of the work done for their members, so we'll take a look at the materials for one of those managed care organizations. The state is providing some very significant information that will come through the MAP system, collecting information from all of the other levels and integrating it with the Medicaid claims. That will be particularly helpful information for you. It's information that would be very difficult to put together on your own. So, let's start with looking at methods for collecting information about your performance. Satisfaction surveys, I'm thinking that's something that probably everybody is fairly familiar with. Gives you a good idea of how your clients are thinking about the work that you're doing. Gives you a good place to start looking at how you might improve your practice and improve outcomes. Critical incident reviews, they're a key piece of the more serious incidents that you might want to be, you are required to be monitoring. Learning collaboratives with other agencies have been very helpful in many instances for people. Supervision. It's a wonderful opportunity to get the information about how your staff are doing and how your agency as a whole is doing. Creating an interagency QA team that will help you to be sure that your billing segment and your care management segment and your quality assurance segment, et cetera, are all in sync with each other. A chart audit tool is a key piece, we think, for collecting information, and we'll be going over that in particular detail. Audits from the health homes on completion of mandated reporting fields, that's in fact a chart audit tool. It will really depend on the health home with which you are affiliated, which type of a chart audit tool you might be using, but we could be assured that each of you is doing some sort of a chart audit for the health home with which you are affiliated or the multiple health homes. Reports from state oversight entities, including health home managed care plans and the state. Lots of ways to collect this information. Let's look to begin with at the chart audit tool that is conducted at the agency level. And for this, I'm going to pass it over to Chris Mangione, who heads up that work for Health Homes of Upstate New York.
Thank you, Adele. So, yes, let's move on to looking at a chart audit tool that we actually use at Honey. But before we go into detail, just review the uses so that these tools, this audit, will allow the agencies to look at their outcomes against state requirements. It'll also allow them to look at their outcomes and compare their agency's performance against other agencies within the health home. Look at specific health home care manager outcomes within their agency. There's going to be times when perhaps more experienced care managers will be functioning at a higher level, and it'll give you an opportunity to maybe suggest that the more experienced care manager mentor one of the newer care managers whose scores may not be where they could be. And it also allows the agencies to compare their current performance against previous performances in an audit that the health home provides. So let's look specifically at the tool. Right off the bat, we're going to be looking at whether the necessary identifying information is there. The agency identified within that record, the client ID number, the SIN number, who the care manager is, what caseload are they carrying. This becomes really important if there's a score that maybe isn't where the agency wants it to be, look at the caseload. There may be, and it's not necessarily deliberate, but the caseloads may differ between care managers. That'll give you an opportunity to look at the caseloads and balance them. Who actually did the review for the health home? What was the date, and what was the enrollment date for that individual? So moving on, we're going to look at one of the segments of the audit is initial documentation. So is there eligibility screening that's been completed? Have they looked to determine, one, that the individual is Medicaid eligible, whether they meet eligibility for the health home? So is the qualifying diagnoses one of the two that allows them to enter a health home, HIV or serious mental illness, or do they have the two qualifying conditions? Do they meet the risk factors? Is the consent completed? Demographic information. Very briefly, I'm going to go through the list because it is important. Comprehensive assessment. Also the FACT-GP functional assessment. Is there a care plan that's been completed? Has there been an addendum done? Are the care manager notes signed and finalized? Just a little anecdote from a recent audit that we performed. We found that while there may be documentation in the record, that those notes were left in draft, which would is not an acceptable documentation. Timeframes are another area that are very, very important and which are reviewed during an audit. So is the comprehensive assessment completed within 30 days of enrollment, as well as the functional assessment? Is there an annual comprehensive assessment for those folks who continue to be enrolled in a health home beyond a year? Is the initial care plan developed within 30 days of the comprehensive assessment, since the assessment drives that care plan? Care manager notes need to be entered within a certain time frame. Attestation that the billable service has been provided. And is there a crisis plan that's been completed within 30 days of the assessment? And is it signed by that individual? Another area is quality. The comprehensive assessment, and these are the domains within the assessment. There's housing, transportation, financial, vocational, physical health, mental health, substance use, relationships in the community, current active providers, medications, and what are the priorities for that individual being served. These are all things that we look at in detail when we're doing a chart review. One moment, just want to catch up. Quality continued here is the care plan representative of the identified needs and priorities that the individual has identified as a priority? Objectives and interventions are person-centered and are developed around the client's needs. Each problem that they've identified, that is the individual has identified either via the comprehensive assessment or in a conversation with you, is identified on the care plan and addressed with an objective. And if it's not, so if you've decided to pursue, make the care plan and make the problem or goals listed according to priority, why are you not addressing something you've identified within the care plan? Just an explanation. The client and team members, they need to be documented in the record as well. And when we say team members, we're talking about the providers who are providing service, if there is support being offered by a faith-based organization, family members, whoever that individual has identified as being important to them and participating with them. The care manager notes need to clearly document the activities that are taking place to address a specific intervention. And they should document active and progressive movement towards the goals that the individual is working with. And care manager notes also need to identify services that are denied, unavailable, or the client's having made a decision not to participate in that particular goal. We need, again, I'm continuing with quality since this is actually I think along with documentation is the bulk of what we look for in a chart review, that the care manager notes demonstrates the care manager's efforts in obtaining the needed services, evidence that they are facilitating care coordination with the care team, evidence that the care plan has been shared with the care team, and then there needs to be justification for discharging the client. So the client's decided that they are no longer interested in participating in the health home, that goals have been met, whatever, there has to be appropriate justification. And that problems are also being referred to providers and that social support contacts that are documented. Certainly we want to see an accurate and active SIN. Once this particular audit that we are using here in Honey is done, there is a score because there are points given for completing a particular area if it's not applicable, and then there are no points given if an activity that should be completed is not completed. So there's a score that's given. We follow up with letters to all of the care management agencies as well as the lead providers, lead health homes in that region, so that the agency gets their score as well as the health home getting their score. The agency is apprised of what that score means. So if a certain score is met, what sorts of action plans are required. It may be a requirement for the action plan may be a requirement for the entire agency, or if there was a deficiency noted for a particular care manager, the action plan may be that it addresses that particular care manager's training needs. In addition to letters to the agencies and to the health home, there's also a review at the quality committee level. So the quality committee is kept apprised of scores within the agency, what agencies actually need additional support and training. And there's also quality initiatives. This is apart from the audits, but still going along with a quality initiative. There are quality initiatives that are managed by the agency. They identify specific initiatives every 2 to 3 months based on the chart audit itself, based on performance reports that we may receive, or based on operational problems that have been identified. So next, we're going to be talking about data analysis at the health home level.
So passing the computer again. So moving on to data you might be looking for from the health home. We're going to talk about something, the official name is the Care Management Data Analysis Tool, better known as the CMART. I'm sure all of you are familiar with the requirement to collect this data. What I think is not as commonly done is to look at the information that gets fed back to your health home from the state. The care management, the CMART data is collected by the health home, submitted to the state, and the state comes back with a report that actually has some fairly interesting information for you in terms of assessing the quality of the work you do. This tool collects standardized care management data for all the members assigned to the health home. The specific outcomes can be compared against state requirements. You can look at the volume and type of interventions that are being delivered, and you can look at the impact that care management services are having on outcomes for the health home. It's a type of information that can help a care management agency understand what their practice looks like so that they can make modifications to improve practice in areas they identify as needing some work. So this is a sample of one of the pages in the CMART report that comes back to the health home. If you haven't seen this, you might ask your health home to pass on to you the results of this so that you can take a look at how the health home in aggregate is doing. This particular section looks at the total number of interventions and the modality. This includes mail contact with an individual, telephone contact with an individual, and in-person contacts with an individual. It's easiest to read this report from right to left. So the very top line, you see 3.5% of the total population, which is 4,775 individuals, the bottom of the middle column. So that 3.5% is 167 individuals, and in fact, that many individuals had 0 contacts by any modality in the course of this quarter. That would be something you might want to look at. Going through it, you can see that 10.5% had 1 contact during the period. 10.5% had 2 contacts during the period. Moving up to 3 contacts during the period, that was 1,144 people, a total of 24%. And then if you add up the remaining counts, it is 47% of the individuals had 4 or more contacts in the course of the quarter for this report. So you, as an agency, could be looking at that and deciding whether you think this adequately reflects the needs of the individuals for whom you are providing services, or are there areas where you might want to make adjustments in this? The next page we're looking at looks not at the modality of contact, but the core service. The health home has 6 core services. This is looking, the top section looks at how many of those services fell within the care management category. This is something that your care managers will report in terms of their documentation of an interface, a contact with the client. And the care manager has to identify whether it was care management, community and social support, care coordination. So for care management, for this particular quarter, just about equal percent had no care management named service. And then 1, 2, 3, and 4. Very few people had 4 care management services, but about 20% had each of the additional values. This is interesting information. Keep in mind, you can only report 1 of these core services per contact with the individual. So there may be some skewing of the numbers. If you look at the next section that we've put on this slide, it's for the core service called community and social support. 75% of the individuals did not receive this service according to the data recorded by the various care management agencies. My guess would be that community and social support is probably a pretty big piece of the work that every care manager does, but in choosing which service to list on the note, the care manager probably chose care management or care coordination or some other service. If this is in fact true that 75% of the enrollees had no community and social support, that would be something you'd want to look at and perhaps start training your care managers on how to work this into the work they're doing. Again, these reports are not terribly easy to read, but it seems to me it's well worth taking a look at it to get a sense of the work that your care managers are doing, both by core service and by type of intervention. Moving on to the managed care plan level. Managed care plans are very interested in the quality of the work being done by the care management agencies providing health home services to their members. So they will, many of them will give you reports that will allow you to compare your agency outcomes against the state requirements and compare health home performance one against the other. So you want to be sure that you are meeting their expectations so that that managed care plan continues to want to contract with your health home and, in particular, your care management agencies. As I said, the practices regarding how much information you get from a managed care plan vary among the managed care plans. What I've put in next is an example from one of the managed care organizations that typically brings reports to monthly meetings with the health homes and encourages the health homes to share these reports with all of their contracted care management agencies. So here is a look at one page of their, it's about a 4-page list of outcomes that they're looking for. So the categories are the health home service. This is starting on the left. Then they give you information on the process goal that they are looking for you to meet. The next column over is the outcome goal related to that health home service. Then they have what they call headlights monitoring, that's looking forward, and then tail light reporting, which is looking backward at information. So let's look at the care transitions row of information. So the core health home service is care transitions. Their process goal for this, for the health homes and care management agencies with whom they are contracting, is that 90% of patients discharged from an emergency department see a clinician for follow-up within 7 days of discharge. Their outcome goal, what they'd really like to have happen in the end, is a reduction in emergency visits. The headlights monitoring, they're looking to see that the agency receives alerts from the hospital that lets them know that there has been an emergency room discharge for one of their enrollees. And then from a taillights perspective, the managed care plan is looking to see that in the record they can find that a complete date for the follow-up visit. Was that required follow-up visit within 7 days? Is the date that that visit actually took place present in the chart? And did it meet the 7-day requirement? And For your information, there are another couple here that you can take a look at to see what it is you might be required to do by this managed care plan. Moving on to the state level, there is something called the MAP. I'm sure you've all heard about MAP at this point, and you may mostly have heard about things that are, delayed. But October 15th is now the date that the MAP system for adult health homes is scheduled to come up. Within the MAP system, there are a set of health home performance dashboards. They were developed to help the provider community, the managed care plans, the health homes, and the associated care management agencies to track progress and then take action to improve performance on the elements that were tracked. Each of these dashboards is an interactive, customizable view. For the topic, there are a lot of different filters you can use to find exactly the information you'd like about your care management agency or health home. You can use these dashboards to look at your agency's performance over time and in comparison to other agencies, and you can drill in to get insights about the population you serve and the performance of your associated providers. It is a very powerful tool. It's scheduled for release later in 2015, is about as specific as the information is at this point. But do watch for these because they provide very good information that will help you in your quality work. The 8 dashboards that will be up in 2015 sometime. First one looks at health home program enrollment. The second one looks at the managed care plan assignment workflow. The third looks at the health homes assignment workflow. Then moving on to the care management agency enrollment performance. How well are they doing enrolling individuals? There's a dashboard that looks at dollars that were paid out in terms of a PMPM payment to the health home and in turn down to the care management agency. They're looking for dollars that were paid out, but the member for whom those dollars were paid is nowhere to be found in the tracking system. Those are dollars that they will be taking back, and so this is a pretty good report to keep your eye on to be sure that you're not going to have payments taken back because the proper information was not in the tracking system. The next one, emergency room utilization for health home members, inpatient utilization for health home members, and primary care utilization for health home members. The goal is to reduce emergency room utilization, reduce avoidable inpatient utilization, and to increase primary care utilization. So it's interesting to note that this aligns almost completely with the DSRIP, which is the healthcare transformation initiative being carried out in New York State. So as a health home, you are a critical part of that DSRIP initiative, and the goals for you as a health home match up with the goals for the DSRIP initiative. So you don't have to be working on multiple things. The same work will get you good results as your health home and presumably would bring down some money from the DSRIP to your health home. So the MAP Health Home Performance Dashboard, here's a link to those dashboards. The release time is not yet determined, The access will be through the MAP system. So anybody in your agency who is able to access the MAP system can actually look at these reports and pull them down. And training is available from the Department of Health. And on the front page of this dashboard, they have a tutorial that you can take to learn how to use it. So here's some sample reports. The first one we're looking, this is an introductory page. It gives you information about what this is all about. The information comes from what's called the New York State Salient Medicaid Enterprise System Health Home module. It takes health home assignment and enrollment data. It marries that with Medicaid claims and managed care encounters, puts them into the 8 dashboards. What's good about this is it takes the information you put into the health commerce system and combines that with the claims information to give you very powerful information. The first of the dashboards we'll just take a quick look at is the Health Home Program Enrollment Dashboard. You'll want to go on and play around with this yourself, but this is just to give you an overview of the type of information you'll be seeing. It's easily accessible and actionable. There are a lot of filters. On the left-hand column, you'll see a whole list of different filters for all, for health home, by care management agency, by county, by managed care plan, by clinical risk group, timelines since inception or the current month. These are, it gives you information both for your business practice as a care management agency and the actual practice of care management. And there are a lot of presentation options, and you can dump it to an Excel file to give you better information. This gives you a look at 4 different, what they call widgets. Basically, enrollment by specific care management agency, by month, over time. It gives you a comparison of how many individuals a particular care management agency or health home has enrolled versus discharged. And then, if you like, you can look at the reasons for discharge. Moving on to the next, health home assignment workflow. This is an interesting one. The red bar is the number of individuals assigned to a particular agency. The green bar is the number who moved from assignment to outreach, and the blue bar is the number who moved from outreach to enrollment. It's clear that we as a health home service line need to improve the blue line. It is particularly short in comparison to the red line that shows you how many people were being assigned. We know there are lots of reasons for that, but I think there is thinking that we can do better in getting the number of people, the percentage of people assigned into actual enrollment. Emergency room utilization for enrolled health home members gives you a look at, this is by care management agency, what is the average ER utilization rate. It gives you in comparison to other agencies in the top section. In the bottom section, you could look at a particular agency in comparison to all others or a statewide average. So very powerful information, which we think that you will find to be very helpful for your quality assurance work going forward. And now, let me move this back to John, who's going to give you some information on quality improvement initiative for a health home care management agency, what it might look like and how you might go about doing it.
Thanks, Adele. I'm pretty sure by now you're saying, hey, you've provided us with a lot of information. And truly we're hoping that it's useful to you. You do need some time to digest. Obviously, we understand that. What we do want to do before we summarize the conversations that we've had is to just go through an example of a quality improvement initiative that any particular care management agency may choose to work through. So this is an example, and it really starts with a problem, and this is a problem that, in fact, the work of Health Homes of Upstate New York has identified through chart review, and that problem is that we see or we don't observe engagement of care teams in the plan of care. So again, this is you have to be mindful of what we're seeing in an audit. If you're looking at the chart and there's no documentation, what does that mean? Well, that really means from somebody from the outside that this hasn't happened. So you've got to be mindful of the actual action that will constitute engagement of the care team in the plan of care, which clearly is an expectation that's placed upon us as health homes. And you have to be mindful of the documentation that reflects that that activity has actually taken place. So we need to be very open in terms of problem identification. Before we move into the process, though, I just want to reflect a little bit that when we talk about quality assurance in any organization, it's so critical that the organization itself really has a culture that supports this kind of activity. And what that means is, as an organization, we're open to learning about the things we do well, as well as the things we don't do as well. And when we identify those things that we don't do particularly well, that shouldn't be, especially at the very beginning, subject to some sort of punitive action. We're really never going to get staff to continuously improve if they are fearful of uncovering opportunities for improvement. So it's so important that we build a comfort level with this process, that we're here to learn. And in learning, we're going to find things we do well, and we're probably going to find things we don't do so well. The key is when we found those opportunities that we've really developed a game plan for addressing them. If we can maintain that culture, that supportive culture of an organization that continuously improves, not only within the world of health home care management, but within other services that they provide, that does move you in a direction of really working to meet the expectations of your customers and your clients. So we've identified this audit result, lack of engagement of care teams in the plan of care. Next step is to collect information. And as a health home, lead health home, Honey, what we would do is survey health home care manager supervisors. Those individuals are supervising the care managers within the downstream care management agencies, to talk with them about their experience related to engagement of care teams in plans of care. Are they seeing it happen? Are they paying attention to it? If they're seeing it happen, are they making sure that the documentation is taking place? After we've gotten that information, we would take some time to analyze the data. What is the extent of the problem? Again, is it that that the engagement is taking place and it's not being documented? Is it that the care manager, as of yet, hasn't really determined how to do that kind of engagement? What are the barriers, depending upon the problem? And let's brainstorm what may help. What are some of the possible solutions? And again, if you're doing this in a productive, person-centered way, which is really, again, you might think of this as a parallel process. The agency itself needs to support its employees in a person-centered way in order for them to provide person-centered services to your clients. Let's talk about the issue. Let's begin to think about what can be done to improve our outcomes, to do this work that we really understand may be important. And sometimes it could be more education, sometimes it could be practice, sometimes it could be documentation. But it really depends on the problem, and by virtue of having an open conversation with those individuals that are part of the work that's being done, oftentimes you can come up with some pretty brilliant solutions that individually we may not have thought of. So that is the next step, identify possible solutions, working collaboratively. Out of that, you create a game plan. It needs to be concrete in terms of a plan. These are the specific steps. These are the people that will perform those steps. Here's when it will be done. Again, think about a work plan. Action, accountable party, due date. Those are all things that will help create the accountability. And then reassess during the next audit. Did you remediate the problem? So whether it's the health home itself or a downstream care management agency, we need to take steps to follow up when a problem's been identified and see whether we've made an improvement. And if we have, great. Can we continue to improve even more? Great. If we haven't made an improvement, let's repeat this process and see what we can uncover that will help us in the area of addressing that particular problem area. If we think back to some of the reports that Adele presented that came out of the Medicaid Analytics Performance Portal, we do continue to see that there are opportunities to improve our ability to actually outreach and successfully engage those individuals that are on the assignment list. Across the state, the most recent number that I heard was, hey, we're successful about 25% of the time. And oftentimes the people that we're successful in reaching out to aren't, well, they certainly will benefit from the service, but we also need to be mindful of those that are a little bit more difficult to engage, many of whom could be individuals that are eligible for health and recovery plan services, that new array of services that will be available once we move towards the Transform Medicaid Managed Care Initiative, which is downstate, will be happening very shortly, and rest of the state is going to be July 1st of next year. So I bring that up because it may be a very helpful process for each care management agency to go through, identifying the problem, it being lack of success in engaging those individuals that are on the assignment list. Look at your numbers, see what your degree of success is, and begin to have that conversation with those individuals involved to see what potential new ways of engaging these individuals might be. And just as an example, I was in a conversation around this particular issue just last week, and one particular agency said, well, you know, we started to use Facebook just to reach out, not sharing any information that would be considered confidential, but to really see who's out there and whether they would be interested in connecting back with us. And they are finding that they are having some success. So I bring that up just as an example of some creative ways of rethinking how we're going to reach out to these individuals. And I think what's also cool about that particular suggestion is it is taking advantage of social media in a very positive way. And that is one of the areas that we always need to be mindful of. Can social media help us do our work better? So again, think about your particular problems, think about your process, try it out and see if you can't come up with some solutions that will really have a positive impact on the services that you provide to high-need Medicaid recipients. So what we want to do is summarize the conversation that we've had today, and these are our recommended actions to health home care management agencies to really begin to assess the quality of your service and the impact of those services on those that you support. So, review existing performance assessment, quality assurance, improvement operations, and expand to account for health home and MCO interaction. Build your process. If you don't have one at all within your agency, it's time. if you have one, it's time to fold in the work of the Health Home Care Management Agency, because the accountability is there. It will be heightened over time. And in fact, if you're providing multiple services to Medicaid recipients, let's see how your health home care management support can impact on those other services. Become familiar with expected health home outcomes for adults and with associated quality measures. Chris went through those earlier, and again, you'll get a copy of the PowerPoint, so please take some time to look at that. Review any health home quality reports that have been provided to date from your health home agency. And really, again, not just say, oh, this looks complicated, I'm going to put it to the side until later. Let's take a deep breath, a cup of coffee, and begin to understand what that means. And if you need a team to do that, please do it. It will make a difference. Identify your agency's IT needs. It may be in order to do the work that needs to be done in an effective quality assurance program for you. You may need to think about expanding your IT capabilities. Totally depends on where you are as an agency. Make sure you have the right internal policies and procedures to monitor the delivery of health home care management services and to demonstrate outcomes. Be clear on what the appropriate process should be, because again, within a quality assurance program, you're going to measure your fidelity to that process. And do your best to demonstrate with what you have that you're having an impact. Other reports will be coming out, as Adele said. That's the next point here. As the Medicaid Analytics Performance Portal and the dashboards become available later this year, please make sure somebody is taking the time to look at those, understand, ask questions, because those are going to be really, really helpful in demonstrating that we're having an impact or in demonstrating that we have an opportunity to improve. Make sure you have a clear understanding of the pathways and procedures for reporting to your health home. What do you expect? What is expected of you to give them? What should you be getting back? And very importantly, when you receive information from the health home, how should that be processed? How is that information used to positively impact the work you're doing? Go to the trainings that are offered by DOH and the health homes. Learn, ask questions. Those are really helpful, a way of expanding your ability to meet the needs of this population. We mentioned this before, another reminder, managed care organizations, that's what the MCO stands for. Your managed care companies are paying for many of these services. They do have expectations. They continue to refine those. We need to understand them and to make sure we have the ability to track our success. And make sure that we do have an internal quality assurance program that really is prepared to initiate internal processes to continuously improve while you're also responding to managed care policies. So you need to be able to deal with the routine set of expectations coming from your customers, coming from your health home, but you also need to be able to take the time to look on an ongoing basis for opportunities for improving your internal processes. It all does come together when you have the ability to really invest in an effective quality assurance, quality improvement program. So that completes our presentation for today. We welcome questions again. If you would please place those questions in the chat box. We will be hearing what those questions are very shortly and do our best to respond to them. And again, if one of the questions is, will this PowerPoint be available after the presentation? Yes, it will. It will be coming out shortly after. So again, thank you very much. We will wait to hear what the questions are. Okay, first question is, are there guidelines that we should be following regarding critical incidents? And I'm going to let Chris Mangione respond to that. The short answer is yes.
Yes. Yes, there are guidelines. DOH issued a policy on incidents and complaints back in September of 2014. They have also indicated that they'll be sending out a revised policy, but we have not received it yet. So I would suggest that you go on the DOH website or use your Health Home Policy and Procedure Manual to review. According to what your agency license is, oftentimes determines which governing body you report the incidents to. But yes, there is a specific policy available.
And, I would just say, as a care management agency, if you don't have that, go to your health home lead, and ask for it, because they really are responsible for making sure that you have that available to you. And right now, we haven't gotten any additional questions. We will sit tight for a little bit to see if you're phrasing those questions as we speak, so take your time.
Or if we may have answered absolutely every question. No one might ask.
Chris is optimistic this morning, believing that we have answered all your questions. All right, well, not seeing any additional questions, we thank you very much for your time and attention today. We appreciate the opportunity to be a part of the presentation, and hope everybody has a great rest of the day. All right, thank you so much.